So, tonight, what we're going to be talking about is the topic of illicit substances and other drugs. So, I'll be honest, a lot of times when we are going to emergency situations, we're going to encounter intoxicated people. Now, that is going to bring out a bunch of different things for us to consider. Somebody being intoxicated is not necessarily an emergency, but we do need to figure out when it becomes an emergency and what we're actually able to do in the meantime. And this is a broad topic. We're going to cover a lot of different things. So test retakes for number 2, the second exam, were not on the table. I did that for the first one because we were getting into the EMS testing. I think we all were kind of trying to figure out the system together. So I'm not currently offering retakes for the second exam or next ones. Unless you had a really poor score and you really think something went wrong, you can reach out to me personally, explain, and I can do it on a per case basis. But for as of now, one take on this test and the future ones. All right, if you have any questions or about that, please just send me an email or whatever. We can chat about it. So, first things first, this is how you know we're getting into the fun lectures as we get further into class, because you're going to see more and more of these disclaimers. We are going to be talking about a lot of different drugs. I'm going to be showing you videos of people who are intoxicated. There's going to be hard subjects that we're going to talk about, some pretty intense images as well. I am doing this for your education. Some of the videos I'm going to show you are were uploaded or were meant in a comedic, light. I don't want to do that. I think there is some inherently funny things that happen when people are intoxicated, but at no point am I trying to make light of or glorify drug use or drug addiction. Okay, the other thing I want to say is I'm not a chemist, I'm not a pharmacist, I'm not a police officer, and I don't condone the use of any illegal drugs, just to get that out there. So, first things first, we've discussed this before, but I want to know from you guys, when is a patient able to say no to being transported to the hospital? What do they need to be able to do in order to say no?
Be coherent and told to advocate for themselves.
Yeah, so they need to be conscious, alert, and oriented, right? We have to ask them
to be alert and oriented times 3?
Yes, at 3 at the very minimum. So, what's your name, where are you, and what time of day is it? Someone being intoxicated, and if they're able to tell you those things, they are still of sound mind. It doesn't necessarily mean that just because they are drunk or high that they lose that, agency to themselves. But there are going to be times, right, when we feel like we need to transport somebody based on how intoxicated they are. So, can you guys still hear me?
Yes.
Okay. Sorry, Michelle. I don't know what's going on. And so we're going to have to figure out exactly what we can do and what we can't do. So this is the first big conversation we need to have is, when is somebody able to make their own decisions when they're intoxicated versus when they're not? Now, I also wanted to review some of the legality portions of this, because in the event that we're hoping to transport somebody who's intoxicated, we are going to need to oftentimes bring police into the situation, law enforcement into the situation. Oftentimes when people are intoxicated, this is where protective custody comes into play the most. And so I just wanted to show you some parts of our protocol and also tell you about some of the police protocols to help you with these decisions. So first, we see the word incapacitated. That's going to be one of the big conversations we have tonight, is determining if somebody is intoxicated or incapacitated. And I'll be honest, it's kind of a hard line to see sometimes. But our protective custody and our protocol says that an incapacitated person would be able to be put into protective custody, police custody, and our goal by doing that is to assure the safety of that individual. Are they a danger to themselves or the public, or both, right? Are they planning, or are they too intoxicated and their actions are going to lead to injuries to themselves or to other people? Or are they having some sort of mental crisis that could lead to the same thing? Our goal with transporting these patients is not to get them in trouble. Our goal is to assist them to the return of functional condition without hurting themselves or hurting other people. If we determine that our patient is a risk to themselves, we can request that police put them into protective custody so that we can transport them to the hospital or an approved place for them to essentially get care for the situation they're in. There are some other parts of this. There are going to be times where a patient is going to be restrained, right? Whether it's by us or by police. Most of the time, it's going to be by police, especially if we're talking about protective custody. I have definitely transported patients who are actively handcuffed in the back of my ambulance. However, there is some caveats to this. If a police officer restrains somebody with handcuffs or whatever, they should accompany us in the back of the ambulance when at all possible. The reason behind this is because they need to be able to unrestrain or unlock those patients' handcuffs in the event that something medically gets worse. This can lead to bad times in the back of the ambulance if somebody is handcuffed and we are unable to remove them. Specifically, a time that I'm thinking of, somebody was handcuffed behind their back after ingesting quite a few benzodiazepines. They were overdosing. They were also kind of aggressive to the police officers before we got there, but the drugs were starting to kick in by the time we were transporting them. We told the officer, hey, could you please ride in the back in case we need to get the handcuffs off behind his back. We also heavily requested that they put the handcuffs in front, but the officer was uncomfortable about that based off of how aggressive this patient had been. The officer also said, listen, I don't have to be in the ambulance with you. I just need to at least follow. I can't leave my cruiser here. I need to drive with you guys. So that's kind of what happened, is he started driving behind us. Our patient was handcuffed behind his back, and he stopped breathing in the back of the ambulance due to the drugs. And we weren't able to get him in a good position to bag him with his hands behind his back, and the advanced EMT couldn't do an IV. It ended up being a pretty big deal. The officer also ended up not following us to the hospital closely enough. So even when we got to the emergency department, the hospital was having trouble treating this guy because he was handcuffed behind his back. And as soon as we could, we got the handcuffs off of him. That was a few minutes later when the officer arrived. So this is just one of those things. I'm not telling you here to argue with police officers. What I am telling you is to advocate for your patient. So you can show them the protocol book of what we're supposed to do. But if they think that that patient is dangerous to us and they want to be restrained, say that is totally acceptable, sir or ma'am, but you will please need to join us in the ambulance or follow right behind in case we need to get the handcuffs off in the event of a medical emergency. So there's some other avenues as well that we can consider. The idea here is we're always going to advocate for the patient if they are in a medical situation or they're overdosing on something, they've taken too much of or too many of whatever. We should bring them to the hospital. However, depending on the level of that, there are some other approved avenues through which we can do. So I'm paraphrasing from the police protocols, essentially, in Vermont. And it says that if an officer encounters an intoxicated person, they can transport them to a residence, to an approved detox center, to the hospital, or to an agreed upon location. So if somebody isn't injured or sick, they might have had a few too many to drink, but they're coherent, that police officer can have a conversation with them. Okay, where's best to get you? Let's get you home. Let's get you to some sober friends. Whatever it means, let's get this person to the best place for them. However, if we encounter, or an officer encounters, an incapacitated person, essentially somebody who is too intoxicated to make safe decisions, that's when they are essentially ordered, they shall take that person into protective custody. And in that event, most likely they're going to be given to us to bring to the hospital. However, again, it still stands, we could bring them to an approved location. That's really going to depend on where you practice. In the Chittenden County area, there's Act 1, which is a approved detox facility. However, it doesn't have emergency support. So for the most part, an incapacitated person is going to be brought to UVM. So this is our first question we need to tackle. When is somebody intoxicated versus when is somebody incapacitated? All right. And I'm going to give you the best demonstrations as I can, but oftentimes this is going to be kind of one of those things you figure out on scene through interactions with the patient. There is no straight up line that I can point to exactly to say somebody is incapacitated versus intoxicated. The line is very thin. But our goal with trying to figure this out is, are they a danger to themselves or others, right? Sure, somebody could be really drunk, but are they going to act in a way that could hurt themselves or others? If somebody's really drunk and they're like, you know what, all I want to do is hang out and order pizza, cool, that's fine with me, right? I don't think they're going to be getting in a car. If they're planning to order the pizza in, that's great, right? Versus, hey, let's go to McDonald's, but let's get pizza, I'll drive, right? Where are my keys? That's a dangerous situation. Somebody who is too intoxicated to register what they're doing as dangerous, they're just drunk, they're just high, they want food, they'll do whatever it takes to get it. I would consider that person dangerous to themselves or others. If they start driving, that would be bad. Now, oftentimes, right, things present differently. So this could be a situation as well. I'm sure if you have been in towns drinking before, if you're of age, you've seen this. Somebody just bawling on the street because something they wanted wasn't available, right? It's one of those things. Alcohol kind of removes the parts of our brain function that make us adults, kind of reverts us back to our childlike nature in some senses, can make you very emotional. I wouldn't say this person needs to go to the hospital, but they should probably get some water and they should get some food. Versus somebody hanging on the roof of somebody's car in traffic, jumping off that roof of the car onto somebody else's car and starting the whole thing over again. That is definitely a call I have been on. And that person was incapacitated. They were trying to hurt somebody. They were going to hurt themselves. So this is the challenging question that you're going to have to use your critical thinking for. When in doubt, if somebody's really drunk, it's okay to bring them to the hospital as long as they consent. Or if you're able to essentially say, I think this is the best possible avenue, you can have a conversation with them, their family, the law enforcement officers. All right. Here are just some examples for you. Let's watch Beth here. So if you couldn't hear what was going on, Beth was trying to order 4 sambucas for her friends, and she didn't realize that this was the DJ booth and not the bar. All right, I would say Beth is intoxicated. I don't know if she is incapacitated. Not knowing the difference between a DJ booth and a bar in a loud, crowded, dark place, I'm not super worried that she's going to hurt herself or others as long as she is not driving home. But let's watch this guy. Shut up, Beth. What do you guys think is going to happen here? What do you think?
He's gonna fall at some point, probably, because he's so unsteady. He could fall and hit his head or fall on someone.
Yeah, absolutely. Do you think he's going to keep his sandals on? Oh. Let's try that again. He got the one sandal on. Lost them both, right? That guy is having too much trouble functioning as a human being, having no control or very little control over his bodily functions. He is incapacitated. If I saw him, he is not going to be able to make decisions smartly. He's a danger to himself. He's a danger to others. So those are just 2 examples, right? And it's going to get a little more clear depending on what we see. but I also just wanted to run this through for you, give you a kind of a tangible way to think about this. So made a little key here for you. Anything in green is something that we might do versus red is going to be something that we don't do. So if we encounter an intoxicated person, they're not injured and they're not sick. For some reason, we encounter them as the patient. Oftentimes that can be from a third party calling 911 or some other reason like that. If they want to go to the hospital for some reason, they feel like they're too intoxicated, we can absolutely take them. Right? These are the times where we're going to sit down with the patient, we're going to have a conversation about what is best for them. That means we can transport them to the hospital or to another approved location via law enforcement. We aren't going to be taking anybody home. We can't transport somebody to a place that is not the hospital, but we can cooperate with law enforcement and say, hey, this person doesn't need to go to the hospital, I don't think, but they should still be transported somewhere else. Could you bring them home? Could you bring them to Act 1? Whatever it be. Now, if they're intoxicated, unsick, uninjured, and they don't want to go, but they're conscious, alert, and oriented times 3, great. Okay, we're going to give them some pointers on safe things to do from here, encourage them to call us back if at all they need us, anything like that, but we can cancel the call. We'll have them fill out the paperwork, we'll call medical control just to tell them what's going on, see what they think, but for the most part, somebody's just a little bit intoxicated, they don't need to come with us. Now, if they're incapacitated, if they want to go with us, that's great. We're just going to transport them to the hospital. That's where they should probably be going. If they are conscious enough to say, yes, I'd like to go, we're going to take that. Even if they are not conscious, alert, and oriented times 3, I would much rather an altered person still voluntarily go to the hospital than somebody altered not want to. Now, in the case that they don't, we are still going to transport them. However, we're not going to be like wrestling them to the ground, throwing our own restraints on them. We're going to request law enforcement to put them in protective custody so that we can then take custody from the police officer, transport them to the hospital, or, the officer will take them to an approved detox facility depending on the situation. Now, if somebody is way too drunk or way too high, they should agree to go with us to the hospital. However, approved locations are also fine. Yeah, Sharon, what's your question?
What if they're underage and they're intoxicated? Does the voluntary transport thing change if they're underage?
So that would be up to
And
their
no
parents.
adult is around?
That would be up to their parents.
So-
If they're
So
intoxicated,
we'd have to call their family? Okay.
yes. Anytime somebody is underage, we need to at least try to get in contact with their parents. If they're intoxicated but not injured and not sick and underage, essentially that's going to be a law enforcement question. They're going to have to take it from there because if they're not sick, they don't need EMS transport to the hospital. It's not really our call anymore. But yes, anytime we are considering transporting somebody under the age of 18 who is not legally emancipated, we need to at least attempt to get in contact with their parents. If there's an incapacitated 17-year-old, we're not able to get in contact with their parents, we're going to try at least, but then we can still transport them with protective custody and implied consent. Now, the other thing I wanted to talk about that's kind of in the similar vein of this, but a little bit different, are... Whoa. Okay, I messed it up again. Free... Here we go. Okay, so the other thing that oftentimes goes together with this is mental health emergencies. Oftentimes, somebody having a mental health crisis has typically taken some sort of drug or is intoxicated as well. They can oftentimes come across as we get called to an intoxicated person and we show up and might realize that somebody is doing this on purpose to hurt themselves because they're having a crisis. All right. There are a couple different things that we can do in this situation. If they want to go with us and they say yes, that's great. We'll transport them to the hospital. They can either go with us to the hospital or with police, whatever makes them most comfortable. Oftentimes, it makes them more comfortable to come with us. This is one of those ongoing things that we're going to need to deal with. UVM is not like really a mental health facility. It is an emergency department. We have a few mental health facilities in the state. We are growing this number, but we still just need to bring them to a place where there are mental health professionals. UVM has them. If they're having a crisis, we need to also determine if they're a danger to themselves or others. And if they don't want to go with us, there are some avenues for us as well. If they are not a danger to themselves or others, if they have not said, I am actively planning to hurt myself, I want to die, I'm planning to kill myself, I'm planning to hurt anybody else, we need to ask them those questions straight up. Essentially, hey, I understand you're having a hard time. Do you have a plan? Right? I know that you have expressed you want to hurt yourself. Have you created a plan for that? Are you intending to hurt yourself or other people? We need to ask them straight up. And if they basically answer anything but no, absolutely not, we have to be careful. If they are not planning to hurt themselves or others, we do have a crisis team or a community outreach team. In some places, mostly Chittenden County areas, there are essentially medically trained people who will respond with police before we typically even get there on the ambulance to triage this mental health crisis. That's who we're hoping will be there first. However, we might need to be the person to triage, oh, this is actually a mental health crisis. We should get them set up with the crisis phone line or the outreach team who can come and essentially manage their mental health crisis because we're more medically oriented. However, if we determine that they are a danger to themselves or others, we're going to need to transport them. However, because they might not be intoxicated, they might be conscious, alert, and oriented ×3, but they have said, I want to hurt myself or other people. That is another level of that legality that we can use where we say, hey, officer, this person has told me they are planning to hurt themselves or other people. I need you to put them into protective custody so that I can transport them to the hospital. Or the police can bring them to the hospital too. All right. So just know, not every single intoxication or incapacitation call due to drugs is due to a mental health crisis, but oftentimes these situations can overlap. All right. Now, there have also been some new updates to our protocol revolving around behavioral emergencies. And we have these two new kind of assessment tools to help us determine if we think somebody is a danger and also how to manage these scenes. So the SAFER model is what you see here on the screen. This is essentially the best practice way of just de-escalating these types of situations and not necessarily convincing, but helping the situation so the patient is more apt to listen to us and not to escalate. So that's like stabilizing the environment. If it's really loud or if it's really bright, if you're at a concert, right? Like we saw Beth or something. Get them out of that room. That can just be overwhelming for somebody, and it can make things worse. We're going to look at the RSAS or RASS model in the next slide, and we're going to just essentially assign them a number, which is going to help us kind of give the hospital an idea of what's going on. We can facilitate identification and activation of resources. Do they need something to help support them? If somebody is having a mental health crisis, they don't necessarily need to go to the hospital unless we find them incapacitated. We can absolutely get family members to come and help, whatever we think is going to be best for them. We're also going to encourage them to take use of those resources, and we're going to only leave the patient in care if we end up leaving of somebody who is essentially qualified or reasonable in this situation. So the Richmond Agitation and Sedation Scale is that number we're kind of assigning them. Essentially, baseline alert and calm is just 0. We're going to move up to pluses if they're agitated, and we'll go down into negatives if they're sedated. So like a +1, that's anxious and restless, somebody who might be like moving around, twisting their hands a lot, expressing that they're anxious, that something is going on. Up to, right, +4, where somebody is actively combative, violent, potentially hurting themselves, other people, or even getting upset at us. That would be +4. Definitely one of those things not safe for us to be around without help. We'll need police. We're probably going to need to be transporting these people. And then all the way down to things like being unresponsive due to ingested drugs. Some mental health crises can put people into more of a sedative state, so we just want to be assessing for that as well. Now, the main topic of tonight is the different types of drugs that you might see in the field as an EMT. What I want to talk about with them is how they are abused so that you can recognize the potential signs of use in your patients, looking at the signs and symptoms that they present in somebody's body, their behavior. I also want to discuss how people abuse these things so that you can pick up on it, as well as other considerations with each medication and how we're going to treat them. Now, that list over there is essentially the list and classification of the different types of drugs that people can recreationally abuse. So we'll be talking about central nervous system depressants, central nervous system stimulants, inhalants, hallucinogens, dissociative anesthetics, narcotics, and cannabis. All right. It's going to be kind of a similar way that we're talking about the medications that we know how to give to patients. That's kind of my goal, is to line it up in a way where you're just going to be able to recognize the signs, indications of use, things that might make you worried about that use, so that we can treat these patients appropriately. So first things first, we have to discuss how people ingest these medications. Typically, a big one is just oral ingestion. That is most common with things like alcohol, right? Somebody needs to drink alcohol for it to be processed in their stomach. It can also be things like taking pills that are going to be metabolized. The stomach will break them down. The medication will then go through our system and into our body. This is typically a slow onset of effects, 15 minutes plus usually, similar to how glucose takes about 15 minutes to get into someone's system when they ingest it orally. Insufflation, this is a fancy term for snorting. It really just means pushing powder into a body orifice for, ingestion. And most commonly, this is what we refer to as when somebody snorts a powder or liquid up their nostrils. This is a rapid onset of effects because it's getting right to the mucous membranes. It's not going to be as fast as inhalation or intravenous access, but it will be rapid because it's immediately getting into the bloodstream. It's not getting processed and broken down in a stomach somewhere. Now, inhalation, this is the act of breathing a gas or a smoke in to elicit an effect. This is also a relatively rapid onset. If you think about it, our lungs are primed to get oxygen into our body as quickly as possible. So when we breathe in, that whole system is aimed at getting whatever is in our lungs into our blood really quickly. So that's why, things like smoking cigarettes happens really quickly, because when somebody takes a puff of that, the chemical is going right into their blood. And it's one of the quicker forms of this, ingesting these medications. Now, the fastest is injection, as long as it's into a vein, right? I'm not talking about intramuscular shots. Those take a little bit longer. But if somebody has accessed their vein and they inject a medication, it's essentially immediately into their bloodstream and being circulated around their body. So it's almost instantaneous onset of these effects. We're going to be talking a lot about intravenous abuse when we get to the opiate section. And then last, but not least, we do have to talk about it. People are weird, man. But yeah, per rectum, the act of pushing a drug into somebody's butt, it does work. People do it. Am I surprised? No. Am I a little disappointed? Yes. All right. It's a gradual onset of effects. It's a mucous membrane, and it does work. I don't know if you guys were in high school or around the time where I just remember kids being like, hey, man, if you soak a tampon in vodka, you'll get drunk if you put it inside yourself. And guess what? They don't smell it on your breath. That's what I'm going to do. And I always just thought that was so stupid. But that happened in my high school. So happens in high schools, happens with adults. Don't be surprised. All right. Our first avenue of drugs that we're going to talk about is CNS depressants, central nervous system depressants. Now, The most common forms of these drugs are benzodiazepines and alcohol. Anyone remember what medication is in our scope of practice as EMT basics that is a benzodiazepine? Pop quiz.
The rectal, it's for the status epilepticus.
Yep.
Oh my gosh, why am I blanking on the name of it?
It has diaz in it.
Yeah.
Diazepine.
Yes.
So basically the same drug, just made for rectal insertion and used medicinally. But there are plenty of pills like Xanax, Klonopin, Valium, Ambien that are in this category that people can take in order to elicit essentially like uber alcohol effects. They're going to have very similar effects on the body and the brain. They're essentially identical to how alcohol works, but it's taken in pill form. Now, lots of benzos are prescribed for people to take for medical purposes. However, they can also be abused, and the effects essentially stack. If you're going to take benzos and alcohol, it's going to play off each other and only make those effects worse. So you can see those medications over there with their very fancy medical terminology names, and then also alcohol with their absolutely 100% real, not made up by me, medical terminology names. And I'm sure you have heard about these frequently. Now, alcohol is one of those things. It is legal if you're over the age of 21. People have been drinking alcohol for a long time. We have evidence like 10,000 years back of alcohol recipes, like beer recipes carved in clay tablets. So people have been making this stuff for a long time. We've been using it for a long time. Oftentimes it's part of like a lot of our culture, especially as Americans. So they're going to have similar effects on the body. If they're combined, these are essentially going to, play off of each other, make things worse. But most of the time what we're going to see is lethargy through like true altered mental status. If you've been around people who are drunk, there's a line where they're kind of stumbly, a little bit slurry, and a little bit tired versus out of it, like totally gone, not thinking straight, really not even present in their brain, but they're still conscious and moving around. So slurred speech is very common. Unsteady movement. Vomiting is honestly one of the more common things if somebody is quite intoxicated on a depressant, especially alcohol. And then one of the other physical signs you might see is if you're assessing pupils, their pupils might be a little bit wider, they might be a little bit more dilated, and they're going to be a little sluggish to respond. So when you're checking that pearl, looking for how quickly their pupils respond, you might see them respond, but they'll just kind of be slower than normal. I'll also be honest with you guys, when it comes to alcohol, it takes almost a superhuman effort to drink enough alcohol where the alcohol kills you. It takes a lot of practice, which I don't recommend you do, and a very certain type of body to essentially be able to drink yourself to death with alcohol. Usually it's over a long period of time. However, people tend to get in situations where they drink too much alcohol, and what ends up killing them is essentially their vomit. One of the more common reasons why people die due to intoxication from alcohol is they fall asleep or pass out on their back. They vomit in their sleep, and they're not able to clear their own airway. They essentially breathe in their own vomit, and they asphyxiate and aspirate. So most often than not, that's why people will die from alcohol. However, when somebody combines alcohol with a benzo, we can see like the toxicity effects of what these depressants do. They're called depressants of the central nervous system for a reason. If somebody ingests too much of them, you're going to see their central nervous system slow down and eventually stop. So reduced heart rate, reduced breathing rate, those are the dangers that you might see if somebody has taken too many benzos along with alcohol. Whereas if it's just alcohol, you're likely going to see a lot of vomiting. So be prepared for that. Get ready to roll patients on their side. If they're unconscious, get suction ready. Or if they're still semi-conscious, sit them up and give them a basin, right, so that they can vomit in. Now, most common for alcohol is drinking it. and with other pills, right, just taking the pills and ingesting them, the pills can be snorted if they're crushed up. And you might be surprised, but alcohol can also be ingested by snorting it. I am sure that is not a pleasant experience, but it can be absorbed through mucous membranes like in our nostrils. Medications like benzos can be injected into somebody's bloodstream if they're processed correctly. It's also kind of rare that that happens. And alcohol is just straight up going to kill you if you inject it into your veins. If you've ever seen the show Always Sunny in Philadelphia, there's like a running bit that they do that, but every time I see it, it just takes me out because like they would just die almost immediately. Alcohol won't like mix into your blood. You're going to create what we call an embolus. So an area of fluid that's not blood in your veins passing through that doesn't act like blood. It can cause like heart stoppages, all that kind of bad stuff, mini strokes. It's just really bad for you. Alcohol is just going to kill your veins and your internal organs if it's in your blood. So don't do that. And also, yeah, people do it. Okay. I'm sorry, guys. We're going to talk about this a lot. People put stuff up their butts. You're an EMT. You're going to see it. I'm sorry. The other thing about this, right, is that oftentimes benzos are prescribed to people for anxiety, for other reasons. They're usually prescribed around 4 to 6 milligrams daily, so not a whole bunch. Doctors don't recommend that you exceed 10 milligrams in a day. However, you know, the people that we're going to be seeing who are abusing these will definitely be taking more than 10 milligrams. Alcohol is also interesting too because of its social aspect. You're probably going to, if you work in the area of a college or of a high school or just like a big drinking town, there's a big chance that you're going to encounter people who wouldn't consider themselves alcoholics, but binge drinkers, right? There are people who don't depend on alcohol throughout every single day, but when it comes Thursday night through Sunday, they are essentially drinking 12, 20 drinks every day. Those what we consider those people binge drinkers. People also have really intense alcohol addictions. You're definitely going to meet some people on the ambulance or in medicine who drink an insane amount every single day, and they are used to that. They have essentially trained their body to need that drug. They've become addicted to it. So you might end up seeing some of those people as well. Now, I do just want to show you some examples of how people might act while on Xanax and alcohol.
Oh, did y'all burn me?
Here, I do want to since you burnt me up.
No. Did y'all burn me for real?
No,
I did it.
Why would
I
somebody
put
burn
the
you?
cigarettes up there in your goddamn hand.
I guess I did it. Yeah, because I
Did
had
y'all
it
burn
down
me?
here and I had my leg. Ow.
So essentially, choose your friends because they might film you when you're really intoxicated and be making fun of you. But this woman is taking a lot of Xanax. She was smoking a cigarette, was unaware that she dropped her cigarette and really burned her. You can also see that she's basically like on the verge of sleep. You can hardly understand what she's saying because she's slurring so much, and she's like nodding in and out during this conversation. So there's going to be a lot of overlap with drugs like this, where if I immediately just saw a small clip of this video where I started interacting with her, I wouldn't necessarily know alcohol versus benzos. I can look around the scene, I can talk to the bystanders, I can ask them if they know what they took, but it's going to present very similarly. However, Xanax and other like benzos, again, they're just like alcohol and pills, so they do tend to pack more of a punch. Now, here's one of those videos that's, you know, more on the comedic side, but just take a watch and you'll see why you might encounter this person.
Man sagt l'chaim und bis freilach und man geht a karahot. Man sagt l'chaim und bis freilach und man geht a karahot.
What's he getting?
Sagt l'chaim und bis freilach und man geht a karahot. Man sagt l'chaim.
He's probably getting water, right? Gatorade. 30 rag. This is a 7-minute video. He's on the floor, still on the floor. It takes him about 4 minutes to get up. Yeah, he was there to buy beer, right? Now, that's one avenue of alcohol. Let's watch the other one that you're more likely to see. Yeah, gross, right? What I wanted to show you that for was a very specific reason. Sorry, guys. What was the consistency of that vomit? It's pretty thick, right? Not very conscious and alert. She's basically passed out with her friend. She was lucky that she's on her side, right? That's why people die from alcohol most of the time. They get too drunk to manage their own airway. They vomit something chunky because one of those things that alcohol makes you want to do is eat. And when you throw that up and you're on your back or not around other people or in a bad situation, you're going to get that stuck in your throat. It's going to asphyxiate you. And that's a lot of times why people die due to alcohol. Sorry to show that to you. Don't need to watch it again. Sorry. Now, how we treat these patients, we're always going to maintain their airway. That's probably the biggest thing we can do. There is no antidote to alcohol overdoses or benzo overdoses. We can't just give them a stimulant and like reverse what's going on. So they're going to be unconscious or on their way to being unconscious. So we're really going to need to monitor their airway. We can do that by positioning them on their side, using suction if we need to. If they're breathing okay, but their SpO2 is low, we can give them oxygen via NRB. If they're not breathing, we can use a BVM. However, any time that we're going to be like ventilating somebody who is a risk for vomiting, it's one of those things where using a BVM, we have to constantly be assessing their airway, making sure that any signs of them about to vomit are readied with suction, whatever we need to do, rolling them on their side. Again, if someone takes enough alcohol and enough benzos together, there is a risk of slowing their autonomic processes, so their heart rate and their breathing. It's less likely that that will happen, but it's one of those things where we need to be assessing their vital signs. If we're seeing depression in their breathing and if like a bradycardic, their heart rate is slow, we want to be worried that potentially they took too many of these drugs and they're actually depressing their central nervous system. Again, what we can do for that is protect their airway and ventilate them, potentially do CPR if it gets that far, but if you can breathe for them, keep their airway clear while you get them to the hospital, that's going to be the best thing you can do. What people who are overdosing on benzos and alcohol need is they're going to need days to sleep it off, right? They are going to have to sleep off the drug they put into their body. They're going to have a rough couple days after this. It's not one of those situations where we have like an antidote. Now, the other thing about alcohol is alcohol withdrawals can actually be fatal. Now, other withdrawals of medications from like methamphetamine, from heroin, opiates, those withdrawal symptoms are really uncomfortable. They make the patient feel awful, but oftentimes they're not going to be fatal. People who are withdrawing from opiates will say they feel so bad that they want to die, that they wish they could, but it's not actually going to kill them. Whereas if somebody has been a long-term alcoholic, and then they go essentially cold turkey, there is a risk of them having a seizure. And in these situations, these seizures get really bad, and people have died from alcohol withdrawals. We also see like hypertension, sweating, fevers, and what we call delirium tremens, which is where somebody who is coming off of alcohol will just be like shaking uncontrollably. It's really just like their body is truly rewiring itself to not need this medication. But if you're seeing somebody who's like shaking, sweating, and they're hot, and if they've said that they're an alcoholic, it's likely that they're going through withdrawals, and we want to be concerned that they might have a seizure. So somebody with severe symptoms like this should definitely get seen up at the hospital. Our next drugs are central nervous system stimulants. So essentially the opposite of those depressants we were just talking about. Now, the big ones on the table are methamphetamine. Some more common ones you might see just in the general population is things like Ritalin and Adderall. These are prescribed to people for medical purposes. However, oftentimes abused. If you have been to a college, you have probably known somebody who has a prescription for these and sells them to people for abuse. It's one of those things. It's not ideal. However, they have a very chemical similar structure to things like methamphetamine. They are amphetamines, so they can have very similar presentations if somebody has taken too many as these other types of drugs. And then, of course, we've got cocaine and crack cocaine, which is essentially the same drug but a different structure and purity. They all have similar effects. Most common that we see in low doses, it's going to be like altered mental status, elevated, like they're agitated. Now, agitation doesn't necessarily mean violent, right? But they're just, anything can set them off. They're kind of high-wired, they're hyper, they're moving around a lot. When you start to take a lot over periods of days, right, they can, produce insomnia. So people might not sleep for a couple days. This will then compound with some of those delusions they might be having, paranoid delusions. Oftentimes, like meth addicts might be thinking that people are following them, or they're really just hyper fixated on the worry that somebody is tracking them, that kind of stuff. And when they don't sleep, this can actually produce sleep deprivation, like hallucinations. So if they've been up for a couple days, that can be bad. Now, there is tangible risk and medical issues when people take too many stimulants. This is the opposite of those depressants. So we're going to see an elevated blood pressure, heart rate, and respiratory rate. We can also see hyperthermia. People essentially have been awake for a couple days doing these medications. They lose the body's ability to cool themselves down. They become dehydrated. They're moving around. The drug is stimulating their system to keep go. And they can actually have heat stroke or hyperthermic emergencies due to their core body temperature. That can also lead to seizures and things like that. And then one of the things we're going to talk about tonight is called agitated delirium, which is oftentimes associated with stimulants and other hallucinogens. But that's a bigger topic that I don't want to just, start right here. I've got a couple slides for it. Generally, agitated delirium is somebody at a completely elevated state of altered mental status, and it's really interesting to see. Now, how people take these medications, if it's a pill like Adderall or Ritalin, they're just going to take it orally. But cocaine can also be rubbed on someone's gums, right? That will give them some of the effects of the stimulant. I wouldn't consider that oral medication, but same vein. Common routes, insufflation. Oftentimes cocaine is snorted. Meth can be snorted. Adderall and Ritalin can be crushed up and snorted. That's one of those quick, easy ways for people to do it. Inhalation is also very common for meth and crack because it's a crystal form and people will smoke it. They have those very particular crack pipes that you might see. Injection is also a way that people take this. And yes, people do put it up their butts. Meth specifically is one of those ones that is a huge problem. It's not on the level of opiates that we see. However, before the opiate crisis really started, it was a methamphetamine crisis. It's a relatively cheap drug that is very, very addictive. It's also very physically destructive, right? I'm sure you've seen similar pictures to the one down on the left side of the screen. The progression of somebody who is a meth addict going from relatively healthy looking person down to just very unhealthy looking. It's really just bad chemicals. So if you smoke it, you're destroying your mouth and your teeth, and it's just really aging you really badly and giving you a lot of mental health and physical problems. This is one of those drugs that just completely consumes somebody's mind, right? Somebody is a meth addict. Their entire life is about getting their next hit of meth. Very similar to opiates. These people need this drug to feel at all normal, and it really just becomes their driving motivator in their life is to get meth, ingest it.
This is a crack pipe.
What's it called?
This is called the AK crack pipe. This is my bitch. Allah! This is not for you. This is called crack cocaine. Yeah, this little shit right here, you smoke this, you lose everything. Yes, sir, your teeth, your hair, and you look just like me. You ugly nigga. Allah! This is not for you or you or you. I love you. I love. This is my bitch right here. Allah! Make love tonight, yeah. I'm Pinocchio. Hello. Good night, Grandma. Hello there. You put that, see? That's called the rock. The crack pipe is called paraphernalia, absolutely.
Yeah, we don't need to see him smoking it. This is also one of those videos where, like, I want you to see what people act like when they've been consumed by this medication. I always just wrestle because the guys filming this are definitely, uploading it with the intent of making fun of this guy. This is an addict, right? This guy's whole life is revolving around this methamphetamine, and you can see he's very aware of what it's doing to him. However, he doesn't really care, right? That's one of those things about people who are addicted to medications and drugs that you're going to need to essentially be ready to see, is that if you want to help somebody, they might know that they need help, but they'd rather do drugs.
It's a crack pipe.
So our treatment for somebody in these situations is we just have to be prepared for them to be unpredictable, right? That's my main thing about intoxication, drugs, and alcohol on emergency scenes. It doesn't inherently make the scene unsafe. However, it does make it unpredictable. People who are intoxicated will act in unpredictable ways. Small things could set them off into anger or into something else. So we just want to be prepared for that. Don't approach them like they're going to hurt you. Be, empathetic and kind, but definitely use your scene safety and be prepared just for anything. Seizures are also really likely in an overdose of stimulants. So just be prepared for that. Maintain that airway. Anticipate higher levels of vital signs. Anticipate their pulse to be high, their blood pressure to be high, and their rest rate to be high. If you're assessing somebody and you feel that they're really hot, if you take a temperature and they have a higher level temperature, definitely consider cooling them. Use cold packs in their armpits and their groin and like the sides of their neck. Turn the AC on in the back of the ambulance, all that kind of stuff. It might, lead to them to have seizures if they're hypothermic. It could lead to other issues, so we just want to cool them down. And again, the acute dangers, what kill people who have taken stimulants, is those seizures and hyperthermic events. Usually the hyperthermia leads to a seizure. All right. Now, again, this can be done with, or not done, but this can happen with any type of stimulant. When I worked at the high school in the nurse's office, there was a situation where a student was walked in by her friend. She looked very sick, and the friend was concerned. However, they weren't really telling us what was going on. I have essentially brought the student into the room, sat them down on the bed, and I confronted the friend, and I said, okay, what did she take? He was like, nothing. And I was like, listen, dude, I know what's going on. What did she take? And he essentially handed me an empty prescription bottle of Ritalin adjacent. I don't remember the exact medication, but it's a stimulant, long acting, and there were 90 pills in this bottle. The fill date was the day before, and the bottle was empty. So essentially, this student had ingested around 80 long-acting central nervous system stimulant drugs. As soon as I learned that, I turned to the nurse and I said, call 911. And when I turned and went back into the room, I told the student, hey, listen, we're going to get you to the hospital. And they immediately started seizing. They didn't stop seizing for a while, so the ambulance came and transported them. But that's one of those dangers. They took those medications probably like an hour before. They were in oral ingestion, so they take a little bit of time. But they were in the hospital for a while after that because they had a lot of stimulants in their body, and they were having more seizures. They're okay, but it's one of those things where it can happen very quickly. Any questions about stimulants before we move on? Yeah, go ahead, Sharon.
I just had a question about the involuntary, where that line is for like the man who was on meth. If he's having trouble, but he doesn't want to go, do you consider him conscious and alert even though he's on?
Is he able to tell me his name, where he is, and roughly what time of day
just
is
that.
it? That's
Okay,
always what it's going to come back
then
to.
he can say no.
Yeah.
Okay.
Even if somebody is intoxicated, they smoke meth in front of you, and then they say, my name's Kevin, I'm in South Burlington, it's roughly 6:30, I don't want to go to the hospital, I want to stay here and smoke meth, right? We can't force them to go. I definitely would try to convince them, but not one of those times where I can force them. Okay, so this category, inhalants, this is a loose classification. It's not talking about things like cannabis where somebody could inhale that to get a high from it. These are essentially chemicals that are not supposed to be ingested by humans. This is where somebody gets a high off of ingesting essentially a toxic gas or chemical. So things like volatile solvents like gasoline, paint thinners, things that have those big warning labels on the side being like use only in a ventilated space. Could be things like aerosols like Dust Off and Hairspray, not the musical, things like that over there. You'll also notice that air duster and stuff like that has started to get more popular within people ingesting it and abusing it, because if you go to like Target or Walmart, their computer spray duster is locked up and you have to ask an employee to essentially let you in to get it because of how frequently it was being abused and stolen from places like that. So just be aware of that. Other things like an anesthetic gases like nitrous oxide. This is, I haven't had a chance to add it to my presentation, but things like galaxy gas is kind of what I've been seeing more recently as the social media trend. It's things like the chemical put into whipped cream canisters and stuff like that is oftentimes nitrous to give it that propellant to come out of the canister that can be abused. Now, one of the interesting things is in Vermont, nitrous oxide is in the advanced EMT scope of practice and up. I could be giving nitrous oxide to people for pain control. However, most services don't actually stock it. It's one of those things we could do it, but we typically don't because, the chances that we really need it are very slim. One of the things that I do find kind of interesting is that the protocol for advanced EMTs and up giving nitrous oxide is the dose is you direct the patient to hold the mask to their face, and the dose is when they're no longer able to hold the mask to their face. That's when you stop, because there's no specific way to dose it. It's just like when the person has enough of an effect where they can't hold the mask to their face anymore, that's when you stop. So if that gives you an idea of what kind of effects it does, that's what people are looking for. Signs and symptoms of use, going to be confusion. Flushed skin is also very prominent with this. These people can also kind of like go nonverbal. They might be alert, but they might not be able to speak to you. They can also be kind of twitchy, which is that lack of muscle control. Other things that you're going to notice immediately is probably the smell. They also might have some of it still on them. If they've been huffing paint or like paint thinner, you're going to smell that acetone. You might see some paint on them. You might see paraphernalia. But really the big trouble here is that these can be very deadly. They can cause cardiac dysrhythmias like sudden cardiac arrest. They can cause seizures, and people can just asphyxiate. You are essentially breathing in something that is not oxygen. And if you are constantly taking breaths of it, your body is not getting oxygen, you'll pass out. And if you're still, if you've taken too much or you're still getting some of that, the waft of it, it could lead to essentially just stopping breathing. I actually remember one of the first times I remember learning about death was when I was in middle school, and my mom basically told me about a kid a couple years older than me in a town over who was found dead because he'd been huffing paint and stuff like that. So I don't know why I have that memory. It's just one of those first times where I remember hearing about drugs in younger people. And it was because these are relatively easy to get. you can go to the store and buy some of these things. They're not illegal, but people still end up abusing them, and they can be very deadly. So the root of this, inhalation, right? How people do it is a little bit different. Typically, if they're using an aerosol, they're going to spray it into a container and then huff the fumes out of that, like a paper or a plastic bag. But one of the more common things you might see if you go to like music festivals and stuff is people selling balloons, which are full of nitrous oxide. They act as though they're selling balloons. When they fill you one up, they hand it to you, and then you just inhale the balloon. That is also one of those things to expect if you are like called to a music festival, right? Or a big concert up at the fairgrounds or whatever. If somebody is presenting with altered mental status, flushed skin, that kind of stuff, it could be that they had nitrous oxide. These are big festival kind of abuse drugs. So signs to look for, like little canisters like that, maybe whipped cream canisters, galaxy gas canisters, and signs of use, right? People like spraying it into paper bags or plastic bags. You might see like paint or weird stuff around the sides of their faces where the line of that bag is. So just be aware. Again, these are dangerous. And I want to show you a video.
Holy shit. What is that? This shit fucking hits like a boom. Like right now, dude, like I feel like fucking fuck your Xanax, dude. This shit only $3 a can, dude. $3, dude. I get as high as fucking meth. Like 10 times as high as meth, dude. Fuck meth. Shit, dude.
Give me try some.
Hell no. Dude, try some, dude. I'm not even fucking playing like this. Oh my fucking god.
Yo, is he dying? Are we gonna do anything about this?
Another example of choose your friends wisely. So you saw that guy essentially use his shirt as a filter. Not very safe. He's getting a lot of those toxins into his lungs. You may have thought that that was like audio editing when he breathed out and swore and his voice was deeper. Nope, that was just because the gas he inhaled is denser than air, so it was like helium but opposite. So that was just him breathing out the lung and speaking of this gas. And that's probably why he passed out, was because he's been doing it and he filled his lungs with something that was not air and breathed out really heavily, and he lost consciousness, right? So can be done quickly. You heard the guy himself. He said it is better than meth. So I'm not really surprised people are abusing these things. What it is, we just got to be careful. There's other considerations, right? Especially when it comes to scene safety about when people are using toxins. If they've been doing it for a while, if they're in an enclosed space, right, we could also be breathing in some of those chemicals. So make sure it's safe for you to enter. Potentially, this is one of those times where if we see signs of a lot of like those solvents or computer duster in a closed space, we might want to call fire, who can go in with some respirators, right? At least get the patient out. Or at the very least, start considering open all the windows, open the doors, get some ventilation in there if they have open canisters or whatever. Maintain their airway. Like I said, like this is basically an airway drug. Somebody is replacing the oxygen in their lungs with this chemical. So what we want to do is give them oxygen, especially if they're not breathing very well. However, one of the risks is just spontaneous cardiac arrest, those cardiac dysrhythmias. So we might be performing CPR if necessary. And there is a risk that when somebody does this, they might just go into cardiac arrest or stop breathing because of what the medication is doing. They're replacing that oxygen in their lungs with this gas. Lots of, like, if you ever watch Always Sunny in Philadelphia, there's a lot of drug use in that, and they make it out as fun. But I use this example because that is how somebody would look if they've been huffing paint. And there's also just the risk, right? If they're mixing their own, if they're just in an enclosed space, it could be bad. All right, we're going. One thing I want to say right now. Break might just be a little bit later than it usually is. I have a specific point in this lecture where there is a break. Just want to let you know that if we get past 6:45 and I haven't said anything. So, hallucinogens. There are quite a few. The first two we're going to talk about are, I'd say, like the most commonly known. Magic mushrooms, also known as shrooms, and LSD. Now, shrooms, this is one of those things, they're a naturally occurring thing on our planet, like cannabis is. People essentially throughout the course of human history have used psychedelic things for whether it's social, religion, or whatever. We do have evidence, again, thousands of years back, of psilocybin mushrooms involved in these kind of things. They're in a weird time, or we are in a weird time when it comes to hallucinogens. Some states have decriminalized possession of magic mushrooms, including Vermont. It's not as big of a crime to possess them anymore as it used to be. This is because there has been a lot of newer research going into hallucinogens, showing that they aren't necessarily as dangerous as we thought they were, and there's even some medical benefit in certain situations for hallucinogens. The big thing with hallucinogens is that people tend to lose a grasp of reality. They're not completely on a different planet, but they can just not be processing what's happening. And so the other thing is that these last quite a long time. Shrooms are like 6 to 8 hours, whereas LSD can be like 6 to 15, depending on how much you take. So people can be tripping and out of it for a long time, which will then lend itself to more dangerous situations. LSD is a synthetic hallucinogen. It was created in a lab, and the goal with a lot of medications that we see on this list was somehow medicinal, but LSD has really not found any medicinal purposes. It's a very strong hallucinogen. It's very concentrated, so if somebody gets a lot of liquid LSD, it can be very dangerous, but most commonly it's taken in low doses for the party effect. Most commonly what you're going to see is very dilated pupils. When somebody's on hallucinogens, their pupils will get really big, so big that like you might not even see part of their irises. It's just their pupils. And the big things with this is like anxiety, delusions, and panic, right? These types of medications really mess with people's ability to comprehend things and oftentimes exacerbate what they might already be feeling. So if someone's in a bad spot, they take a drug that distorts their ability to, comprehend. It can oftentimes be very anxiety producing. Now, another hallucinogen that is kind of a mix, this MDMA, Molly, this is a hallucinogen that is also mixed kind of with a stimulant. So while we're unlikely to see overdoses of magic mushrooms or LSD, people can have pretty severe reactions to MDMA because it does have that stimulant effect to it. There were, I don't know if they're still going, but there have been a lot of studies showing that MDMA has some merit in treatment of PTSD in conjunction with psychotherapy. You're not just like prescribing somebody Molly to take whenever they want. It's that in a psychologist's presence, they take a regimented dose. Not the biggest one that's coming around. Ketamine is actually the one that's been showing most promise with that. But essentially, the danger here is it's a combination of that hallucinogen and a stimulant. So people tend to want to take more of it. They also tend to do these drugs in situations like at concerts or raves where they're going to be dancing a lot already in crowded areas and hot areas. They also might be consuming alcohol, which is just going to kind of exacerbate some of those effects. So people who are doing a lot of this are at increased risk of like a high heart rate where it's just like too fast, hyperthermia and seizures like we would also see with stimulants. The other thing I wanted to just like talk about when it comes to hallucinogens is oftentimes, in media and pop culture, someone takes a magic mushroom or like a hallucinogen, they essentially are transported to a different world where they're seeing, characters, cartoon, like Darth Vader walks in, whatever it is. That's typically not what people are experiencing when they take hallucinogens. What they tend to see is just an exacerbation of patterns in their vision. So this is just kind of a video that somebody put together to try to demonstrate what somebody on a hallucinogen might see. So it's less that they're seeing things that aren't there, but what this video doesn't really convey is the state of mind that they're in. The people I've talked to who are on these drugs, it's that there's this huge change in how they're perceiving things. So while it just might look wonky and wavy, they might perceive it as something else. It might cause them anxiety, that kind of stuff. But really, they're not completely in a different world visually, but they might be mentally. All right. So I just like to clarify that people aren't seeing things that aren't there all the time. There are some drugs that do that put people completely out of reality. But LSD, Molly, shrooms, they aren't those types of drugs. How people take them? Typically orally. Oftentimes, it's like people will make teas out of the mushrooms. They will eat them. MDMA is often in a pill form like you see down there. When it comes to LSD, it's mostly taken what I'd call like sublingually, actually. They put it on a blotter, a piece of paper. They really just drip the chemical onto it. They put it underneath their tongue or pad their sides of their mouths, and the drug will slowly start to absorb. That's pretty much the most common way for LSD to be taken. Insufflation is possible when it comes to MDMA, and then even inhalation is possible. It's not as common now, I don't think, but it is one of those things where if somebody has liquid LSD, you can dip flower stuff into it. So people dip cigarettes, they dip joints, they dip other stuff and roll them into cigarettes in order to smoke it and get the LSD effect. I have also known this to be in situations where somebody has unknowingly been dosed by a hallucinogen when they take a cigarette or a joint from somebody that they don't know who has dipped it in a hallucinogen. Now, treatment for these situations is where you gotta be kind of creative. Be prepared for sudden changes in demeanor, even more so than like a stimulant. Like I was saying, people on hallucinogens are really not processing very well, and they can get stuck on a specific topic, a specific phrase. They can get really jammed up in their brain. And so this is one of those times where you got to kind of be creative. Now, I'm a huge advocate of not lying to your patient, of being as honest as possible. Keep that in mind, because in this situation, when people are out of reality, when they are stuck in a delusion, the last thing we want to do is affirm that, but we can and we do want to know about it. It can be very helpful. Here's the situation that I'm going to talk to you guys about. When I was on St. Michael's Rescue, we got called into Winooski for somebody who was intoxicated. When I got there, these parents ushered me in, and their adult son who had been living with them was incredibly agitated. He was really anxious, in a panic attack, essentially. And he was really honest with me. He said, look, man, I took a lot of drugs. I did some LSD, I did some shrooms, and I also think I did something else. I was with some friends. I don't really know. But what is happening right now? I sound crazy, but there are freaking demons outside, and I can't leave my house, or they are going to kill me and bring me to hell. And I said, whoa, okay, that's intense. But hey, man, you called the right people. You see that ambulance outside? We're St. Michael's Rescue. You know who St. Michael is? He killed the devil. We have priests up at the college. They come by our station. They bless our ambulances. There's a cross right on the side. You could not have lucked out more. You are with the best people. And he said, really? Oh, that makes total sense. And I said, great. When you're with us, those demons can't physically hurt you. And he said, great. So we walked him out to the ambulance. I showed him the cross on the side. We got in the back. We started driving. I said, hey, are there any demons in here? Are they still outside? And he said, no, they're following the ambulance, but they're outside. I said, great. They can't get in here, I promise you. And so we brought him to the hospital. In the back of the ambulance, he got distracted. He said, can I play Pokemon Go? I said, absolutely. The only thing I can't do is pull over, right? And he's like, okay, that's fine. Oh, cool, I caught a Squirtle or whatever. We got him distracted on his phone. He stopped thinking about the demons. We got him to the hospital. He started freaking out again when we got to the hospital because it is a big lot of stimulation for somebody in that situation. But as far as I'm concerned, he was calm and chill in the back of my ambulance, and that's what my job was. We got him there fine. So at no point did I really lie to him, except for the fact that, like, priests don't come and bless the ambulance. But you might be creative like that. I never affirmed to him that I saw the demons too. I never said, yo, man, yeah, those demons are going to get you or whatever. I said, hey, while you're with us, nothing's going to hurt you, right? I didn't necessarily say, yes, there are demons outside, but I did confer with him to show him that he's safe in a creative way. So think creatively when it comes to these situations, but I also got lucky in that situation. Plenty of other times I've been around people who are hallucinating, and no matter what I've done, they've been agitated. Be prepared as well to safely restrain these people. This is one of those situations where they don't really know what's going on. They can get combative. Combative always requires context. It's not personal. They are just scared. They're not entirely sure what's going on. We have soft restraints. There are safe ways to restrain people. This is also a time where we can call for ALS, who can chemically restrain somebody. That means essentially sedate them so that they're asleep. We monitor them. They're given a certain amount of ketamine essentially to put them unconscious. We bring them to the hospital where they can then wean off this, hallucinogen that they've been on. Again, MDMA can cause hyperthermia and seizures. And for the most part, when we talk about injuries and deaths, when it's related to LSD and mushrooms, it's most oftentimes due to accidental injuries. Another situation that happened when I was on St. Michael's Rescue was a student had taken quite a bit of LSD at around 3:30 in the morning. And at around 6 a.m., he was spotted sprinting essentially naked around campus as fast as he could. He then assaulted a public safety officer and broke their collarbone. Rescue showed up with some extra police because he had run off again. They were treating the public safety officer, and they saw him come around about like a football field away, just like get out sprinting directly for them as fast as he could, right towards the officers and the EMTs. It took 3 officers and 3 tasers to actually put him onto the ground. He essentially shrugged off the first 2. They had to really wrestle him to the ground. He did not know what was going on. Another situation involved somebody jumping off of a bridge because they were too high to recognize what was going on. They were scared and they were running, right? So most of the time when people are in bad situations due to hallucinogens, it's because they hurt themselves accidentally or other people. So just keep that in mind. Those were hallucinogens. And like I said, those don't cause people to go like really out of reality. They're going to be harder time perceiving it. Whereas somebody who takes like a dissociative anesthetic, these can produce like true altered ability to function, to even perceive that you are on Earth. Ketamine, you may have heard more about recently. We do carry it on the ambulance. It's in the paramedic scope of practice. There is some medicinal function to it. It was developed originally as like a horse sedative, but it is also another commonly abused drug. The goal with ketamine in psychotherapy and medicine is that it is a weird medication where it causes somebody to dissociate. So if they take enough, they essentially report feeling that they are no longer in their body, that they are looking at themselves or just like not in control of their body or not present. People call that a K-hole, where you take too much ketamine and you essentially fall into an abyss. You might be conscious and doing things, but you are not there. It is showing some merit for treatment of PTSD and depression. Again, in conjunction with actively being around a psychologist who is trained, and they are administering very low doses. They're not sending people into K-holes for this therapy. The idea is that if somebody can dissociate from their problems a little bit, they might have a better outlook with that psychotherapy. It's actually showing a lot of good merit. It is possible in Vermont. If you have PTSD or depression, your doctor can recommend that you might need ketamine therapy. Now, PCP, completely other avenue. This is no medical merit whatsoever. It was originally developed to be an anesthetic, and then the people who had it just started becoming psychotic while they were on it, like doing crazy things that no sane human would do. It's that drug where if someone's on PCP and they're really going, they essentially don't feel pain. They don't really know what's going on, and this can make these patients really hard to wrangle and get transported because they're agitated, they are going, and they don't really feel pain. I remember seeing a video. I've never been able to find it. I didn't want to show this to you guys, but essentially a guy on a lot of PCP was naked. They tend to get hyperthermic, right? So they tend to strip their clothes off. He climbed up one of those city telephone poles, one of those wooden ones that are really old and have a bunch of those like splinter things hanging off, and then slid down it. And he essentially had multiple impalements of giant pieces of splinter through him, and he just walks away. Didn't even notice, right? People do not feel as much when they have this drug, and they are oftentimes really elevated. This also brings us back to like that agitated delirium conversation that I want to have, because this is one of those medications that's oftentimes associated with it. Now, some honorable mentions I have here. They're less commonly abused, and they aren't as often seen. However, they are being talked about. One is called DMT. This is a naturally occurring molecule in almost all living things. However, if it's ingested in high enough doses, it produces like intense hallucinations where somebody is unconscious for about a period of 15 to 30 minutes and they live out untold amounts of things in their brain. A lot of people wake up reporting having talked to God or an alien civilization that they completely saw inside their brain. Really interesting presentation. We typically don't see people because of this, because of how short the effects are. And similarly to salvia, which is another like short-term but very intense hallucinogen. Again, most of the time if we see somebody because of this, it's because they hurt themselves by accident or in a situation while they were on these medications. It's honestly crazy how fast and how intense these drugs work. And for an example here, I found this guy on YouTube.
Salvia, take one.
Is just going to show you himself smoking salvia as if that's like cool, I guess. But what I'm going to do is I want to skip around the video a little bit and just show you. This is an 8-minute video and show you how intense these effects are. So he's just smoking it. It is like a plant like cannabis. It's in the mint family. But he just took his first hit. That's...
Don't die on me now.
That's his wife in the background.
Oh my God.
What are you feeling? What are you feeling?
Oh my God.
Can you... You're
Oh,
holding my hand.
No. Oh my God.
What?
Oh my God, I can't get out of my head. He's closing up on me. The whole room's closing up on me. Holy shit.
Okay.
Wow. Wow.
Don't open it.
Oh.
I hope you're not fooling me.
Oh no. Oh my God. Oh my God. Oh. Wow.
So, if you watch the entire thing, the first like 5 minutes are him panicking and screaming about like people who are trying to kill him. And then the last minute is him talking about how great it was. Salvia is really, really weird. The other videos that I could have shown you are the people who smoke it and then panic and jump out of their window because they don't know what's going on. These can be really, really intense situations. Somebody is not present and they can absolutely hurt themselves by accident or other people.
Salvia.
Also, just if you're gonna do drugs, don't post it on YouTube, right? That's just stupid. Now, like I was saying, these are medications that were designed to dissociate and put people to sleep, essentially to sedate them. And these can produce like true visual hallucinations where people are seeing things and engaging with things that aren't present, people, entities, whatever it is. And people who take a lot of these drugs will report very similar kind of style, really intense hallucinations. So keep that in mind. If you are around somebody who is actively high on DMT or salvia or PCP or a lot of ketamine, they might be completely out of reality, not even present. Which leads us to the agitated delirium conversation. This is a phenomenon that we don't entirely understand. It was first studied in the 1980s, and it's based on the idea that stimulant drugs and dissociative anesthetic drugs can cause people to become delirious and violent. Now, this is still debated upon. There's not a lot of evidence to show that it's exactly due to a drug. A lot of times it's in combination with potential mental health crises and a stimulant or dissociative anesthetic. However, that's happened enough times where we register it's a risk, but some of the things about it are a little bit biased. The main reason behind why I say that is it was always touted as having a really high death rate. However, the mortality rate is directly tied to whether or not the patient was restrained. And because they're typically combative and agitated, the restraints are more firm. So we're not entirely sure if people are dying because of the drug or positional asphyxiation, something along those lines with providers, law enforcement, EMTs. All right. However, we do see it enough where we kind of categorize it. It's really altered, severe paranoia, huge agitation, not really any discrimination in who they might hurt to get out of a situation, resistance to pain, and it's also one of those times where it's like people exhibit strength we didn't know was possible. The main risks, again, positional asphyxiation, but also like hyperthermia is one of those risks, and sudden cardiac arrest. So this is one of those things we don't see it all the time. It is in our protocol book. We do have a section about it, but again, it's one of those things we are still trying to figure out. We're not entirely sure what exactly is going on with these patients. Is it a personality thing? Is it a combination of mental health crisis and a drug? Is the death rate because of how they're being restrained or because of this medication? We're still figuring it out. All right, but I do have a video to show you. We're always just going to do routine patient care in these situations. We don't have a drug or really anything that we can give to them. Manage their airway, their breathing, and their circulation. Fix any potential wounds that they might have. Used approved restraints if you have it to mitigate the effect of potential asphyxiation. So soft restraints in the prone not in the prone position, in the supine position. Keep their airway protected. Here's our Vermont protocols about it. And I'm sorry, I don't know what's going on with my green screen today. It just doesn't want to green screen completely. So I'm sorry if you can't read parts of it. But essentially, this is just what our protocol books say. This is the only section we have on it. We don't have a full page, but it's just talking about what you might see and what drugs are typically associated with this style of presentation. Now, here's the video I wanted to show you.
Hey, get on the ground! Hey, get on the ground!
Just sit down, man.
Find the toll traffic for Chicken Clark. Find the Court Ave.
Come on, man! Hold up, dude. We got the ambulance for you.
Chuck, lay down, dog.
Sit down!
Chuck, lay down. Lay down. Lay down. Lay down.
Some of that strength.
Lay down. Lay down.
You He's resisting pepper spray. Now, I wouldn't consider him necessarily violent. He's not attacking these people, but he is trying to run away. He has hurt himself, whether intentionally or not. You can see the blood on him. He is disrobed because he is extra hot. He's just trying to cool down. But then also see how many officers are here, and it's going to take pretty much all of them to restrain him. And it's situations like that that makes us uncertain on why these people die in high-stress situations where there's a lot of people trying to restrain one person who is really combative. It's very easy for it to slip into positional asphyxiation. So we just need to be very careful. We need to protect ourselves. These patients could hurt us or others, but we also don't want to make the situation worse by positioning them or restraining them in a way that's dangerous. Okay? So keep an eye out for those types of signs and symptoms. Somebody really hot, agitated, not really thinking straight, potentially have been hurt themselves or hurting other people, or just really resistant to help. That's typically what we see, and most of the time it is in conjunction with one of those medications. Bath salts is another big one, salvia, LSD, ketamine, those types of things. How people take these: ketamine can be taken in a pill form. PCP can also be put into pills. Like I was talking about earlier, people can dip these, flower type things into these drugs and then smoke them in cigarettes or cannabis. They can be snorted if they're in a powder. PCP is injected. Ketamine is also used IV and IM. And I would not be surprised if there was a per rectum route for these medications. Don't know off the top of my head. Haven't personally seen it, thankfully, but I wouldn't be surprised. Scene safety is always going to be a big one here. But again, maintain their airway. Give them oxygen if it's possible. Really, these times is where we have to be psychologically first aid, where we're going to try to talk to them. We're going to try to de-escalate. One of the most important things for EMTs to do is just be calm. If you approach somebody calm and collected and they are not, it's going to hopefully inspire them to meet you at that level. If you approach somebody at their level, if they're agitated, it's only going to get higher and higher levels of agitation. But if you can bring it down, that's the best possible route. Be prepared for potential sudden cardiac arrest just out of precaution. But again, make sure you are restraining this person safely. If you are not actively the people restraining them, if you are working with law enforcement, your job is to keep an eye on their ability to breathe. Do not hesitate to be vocal about if you think that patient is unable to breathe. You are the patient advocate. The law enforcement officers, their job is to de-escalate a situation. As we know from history and how things go, that can oftentimes go wrong, whether it's due to provider or officer bias. I'm not telling you to start fights, but what you need to do is advocate for the patient. So do your darndest to do that, protect their airway, but also make sure you're protecting yourself and other first responders. Okay, let's come back. I do want to give you a break, but we have a lot still left to cover. It's really important. So let's come back at 7:15. I'll give you 10 minutes if that's cool. All right, 7:15. See you then. Okay, so we're going to do something a little different here. nice. We're going to talk about opiates. Opiates are also known as narcotic analgesics. They are medications that are meant to reduce pain in a similar way that alcohol does. It's a central nervous system depressant. However, these have their own category. They produce depression in the brainstem activity. Now, there are quite a few opiates. The first one was opium, where we get the term opiates because all medications come from this opium. It's made from the milk of the poppy flower. You guys been around Vermont long enough. If you haven't seen a milkweed, that's exactly what a poppy kind of looks like. Has a bulb and it excretes this kind of sappy tar-like liquid that produces some pain relief. It was often used for medicinal purposes and also abused through history. And it looks like this. Now, people saw the use of opium and they registered its medicinal purposes. People in a lot of pain have some of this drug. They don't feel as much pain in a very prominent way. So humans do what humans do. People abused it, but we also bettered it, and with the attempt to make a medication. So from opium came morphine, the original narcotic medication. It's a very strong analgesic effect, and we saw it first kind of used in some of the first world wars, like in one of these things, where patients and soldiers who were severely injured were given some relief by this medication. It can completely eliminate some very severe pain. Now, again, morphine was the first step, and people tried to make it better. So heroin was created. If you don't pick up on the trend here, heroin was first created to be a replacement to morphine, a stronger medication. In fact, Bayer, he has aspirin, right? We have that in our scope of practice. The same company who makes aspirin, Bayer Pharmaceuticals, in the early 1900s, created and sold a child's cough medicine that had ether, cannabis indica, and heroin in it. I guarantee you those kids didn't cough. But it also just shows how science works, right? We started using this medication. We didn't have a lot of research and all that kind of stuff back then. And we realized it was addictive, detrimental to health. And so heroin got phased out of medicinal purposes. Here are some of the forms of heroin that you might see. It is now solely an illicit drug, a very common one. Depending on how it's made, can be into these different kinds. Typically, we'll see white, brown, or black tar heroin. I'm showing you this for a purpose that I'll talk about in a little bit. I'm not showing you how to buy heroin. Do not do that. This is going to actually matter for how we talk to our patients and treat them. Now, again, as humans do, we tried to create and better what we already had. So fentanyl was created. It's approximately 10 times more potent than morphine, and it does work really well to eliminate pain. Like I said, paramedics in our state carry fentanyl on the ambulance to give to patients who are in a severe amount of pain. One thing I want to clarify is how strong it is. We would dose morphine in milligrams. We dose fentanyl in micrograms. So we give patients very, very small amounts of this medication to elicit pain suppression. Now again, we created something stronger called carfentanil, originally developed to be a tranquilizer for elephants. It is approximately 100 times more potent than fentanyl. This was actually a really big worry for us a couple of years ago when we weren't entirely sure how these things were gonna play out. But essentially carfentanil, if somebody takes it, the risk of them overdosing is increased by like 100 times. It's very potent. Now, I put up this red box that there is no pure heroin left in the United States for a reason that is shown to be true. Out of almost all of the overdoses that have been tested in like their blood and whatever they took, majority of the substances in their body are not heroin, and heroin is cut with quite a few different things. Oftentimes for a couple different reasons, and I'll explain that in a second. So the idea behind cutting a drug with something that is not that medication has a couple different purposes. Here is a lethal dose of pure heroin. Here is a lethal dose of pure fentanyl. And here is a lethal dose of carfentanil. Giving people the benefit of the doubt. People who are addicted to these medications are probably not concerned with what they're taking, they just want the drug. However, they might not know exactly what is in what they're taking, right? If I asked you to open these containers and pour them all out into the same place, into the same pile, and then I asked you to separate the fentanyl from the heroin and the carfentanil, you wouldn't be able to do it. Similar to how people might overdose. They get what they think is heroin when it's dosed with a little bit more fentanyl and their tolerance isn't used to it, and they overdose taking a very similar dose to what they might consider normal for them. The other thing, giving people not the benefit of the doubt, is that dealers make more money by cutting fentanyl into drugs. If a dealer has a big package of heroin and a small package of fentanyl, they will cut that heroin in half, save half of it, take that first batch, mix the fentanyl into it, and then distribute it with the intent that people might overdose. Because when addicts hear, oh, there's been an increase in overdoses in this area, they don't get worried for themselves. What they hear is, that guy must be selling some really good stuff. So when that dealer runs out of that first mixed with fentanyl batch, they have an increase in buyers. So they take that other half of the heroin, they mix it with something like vitamin B powder or another powder that looks similar to heroin, and they sell it for the same price. People don't get as high, but they're also injecting things into themselves that aren't the medication. So that's one of those things. That's why things get cut. However, there are newer drugs too that are really starting to worry us, that are being cut into the heroin supply, essentially. There is no pure heroin anymore. It is all synthetic opiates mixed together in these weird concoctions. Almost all of the tox screens that come back show just a huge diversity of opiate-like drugs in this heroin. This is a question to you. I want to hear what you think, because I have heard a lot of different things about this topic. Is it dangerous for us to help somebody who is overdosing? What do you think? No wrong answers.
Yes.
Why do you say that?
Kind of like, I always just think about, it's like echoing. Is it echoing on your side?
No.
Okay. Kind of like, I've seen like videos and stuff of like police officers accidentally touching a substance that's on a person and overdosing. So kind of the same deal. If we're touching and helping these patients, we have potential of exposure to unknown substances that they could have taken, needles in their pockets,
sure,
things like that. So
yeah, that makes total sense.
Same thing as like law enforcement.
For sure. Yeah. Michelle, you said no. If you don't mind, do you want to tell us why you say no?
The question was dangerous to help the person, right?
Mm-hmm.
I think any risk can be mitigated. And I think that the majority of these, you aren't necessarily going to be affected through touch. Like, I don't think it's going to be absorbed through the skin. maybe if you accidentally inhaled it or got it in your nose or in your mouth. But I think overall, I think risk can be mitigated.
Sure, absolutely. And then Samantha, I'm just going to read what you wrote in the chat. It is dangerous to help people who are overdosing because they can wake up angry or mad after they've had Narcan. I'm really glad that you guys all said this. This is the spectrum of the conversation that we're having in first response. I really like, Nikita, how you mentioned those videos. Sam, I really like that you mentioned that idea of Narcan. Here's the deal. No. Fentanyl and heroin do not absorb through skin unless they are specifically designed to in fentanyl patches, and one fentanyl patch would not have enough to make you overdose. Pricking your finger on a needle that somebody may have used to inject heroin into you is not going to produce or put enough drug into your body to cause you to overdose. You are at more risk of developing a disease like hepatitis C or HIV that person may have had on their blood. Opiates do not become aerosolized. They do not go into the air. So powder in the air is not super dangerous. You would need to be in a very small, enclosed, unventilated space, and there would need to be enough opiate in the air to produce like 95% of the air quality being opiate. Okay? You are at very little to no risk of overdosing by helping these people. Nikita, I like that you mentioned those videos. If you watch those videos again with some EMT knowledge, you will notice that the officers who touch or are around those substances do not show evidence, physical evidence, of opiate overdoses. Opiate overdoses present with decreased respiration, unconsciousness, and pinpoint pupils. All of the videos I have seen of a law enforcement officer overdosing on scene, they are presented with agitation, breathing too fast, tachypnea, and anxiety. This is a study that is showing, or that essentially tested these officers. They basically said that of all the officers who agreed to be tested, no opiates were found in their system, and the other half declined to be tested. The only way you're going to overdose by helping somebody who is overdosing is if you inject yourself in a vein with a large dose of an opiate. If you rub heroin in your eyes or you snort a line of fentanyl off of the patient. If you have common sense, you follow BSI and PPE, you wear gloves, you safely dispose of any needles that you find, and you don't unnecessarily interact with drugs or paraphernalia, you are at little to no risk. This is one of those topics, opiates in general, these are one of the topics that we need to talk about. The opioid epidemic is raging in Vermont. We are a small state, and we have one of the highest per capita overdose deaths in the country. And I remember when I was taught that we were worried about this. We hadn't had enough studies on carfentanil and fentanyl to know if it goes through skin or not. We were given, me as an 18-year-old when I joined rescue, was given extra doses of Narcan to potentially give to myself or other people on these calls. We were worried. But we're medical, and we follow science and studies, and it is shown that it doesn't happen. So again, I'm not trying to create a rift between law enforcement and EMS, but their education on these things stopped at you could overdose by being on these scenes. They weren't given proper education, and so what we see in those videos is signs and symptoms of a panic attack associated with the fear of overdosing. The other thing I like to point out when people combat this is, okay, so a first responder overdosed by brushing against the medication when the person that they might be taking it off of is not. Right? They might have been overdosing because they injected themselves or they took a large dose, but you're not going to overdose by brushing against somebody or touching them. Okay? Help these people. Protect yourself. Have common sense. Wear gloves, mask, eye protection just in case. But you're at little to no risk. And I stand up to this because a lot of what I have seen is anti-addict bias. Our job is not to fix them of their addiction. Our job is not to judge them. Our job is to keep them alive. So the routes in which people abuse these medications are vast. If it's a pill form, they can take them. However, it is less likely to be abused this way. It's a slower onset, and the people who are addicted to these tend to really like the quick onset. Inhalation, insufflation, and injection are the most common routes of abuse. People smoke heroin, they smoke fentanyl, they inject it into their veins, and they might also snort the powder. Per rectum happens. Watch Train Spotting, if you haven't seen that movie already. Now, you can see the process here. It's not just as simple as someone taking the powder and putting some water on it and injecting it into their body. There is a process that they have to go through to get it ready to be injected, which is one of the reasons why I showed you the different types of heroin, because the process that is required for those different types of heroin to be broken down into injectable can also lead to some other health conditions, which we'll talk about in a little bit. Some signs and symptoms of intravenous drug use, not necessarily opiate, are things called track marks, like you're seeing here. They are essentially evidence of these people continually injecting themselves with these medications. So you're likely to see infected or just consistent hole marks, like an IV needle, along the lines of veins. Typically, people will start here because that's the easiest. And once they have essentially blown out those veins and they're not able to use them anymore, they will switch to different places. It can be in the feet. It can be anywhere where there's a vein. When I worked at the plasma donation company in Colorado, part of my job was assessing people for track marks. The routine was, all right, show me your arms, flip them over, show me your legs, open your toes and open your fingers, let me see in between there, lift up your tongue and let me look at the veins underneath your tongue. People inject into any vein they can get. I transported a man with an infection in his penis because he was routinely using the vein in his penis to inject drugs because he didn't have any other veins. This can lead to sepsis. These can get infected, all sorts of other things. Now, I'm going to show you some clips from multiple different videos. This one is essentially a guy who lives in Philadelphia, and his whole entire thing he posts to YouTube is he just has a camera facing out the side of his car, and he drives through Philadelphia. This is him driving down Kensington Avenue, which is known as one of the bigger areas for opiate drug use. This is a very common sign of opiate use. Somebody essentially passing out while standing up. They're not necessarily going unconscious, but they are going in and out. They're able to keep standing up. It's kind of insane how far of a lean you can see, but yes, people do this. These two are drawing up and going to inject right here on the street corner.
The addicts cook the powder. Syringes are filled, preparing a drug that's now the same price as a six-pack of beer and cheaper than cigarettes. Chasing a high that's ever harder to reach. Greg and Stacy live rough here. Lower Wacker Drive, home to Chicago.
Now I showed you that for a reason. Anytime on the ambulance that we are going to do something like draw blood, so a finger stick, like we talked about, one of the main things we do is always sanitize the area before we ever put anything into somebody because of the risk of infection. You just saw those people with incredibly dirty hands using a old liquor cap bottle to prepare their drug that they're going to inject into their body. We don't know what type of water was in it. White powder heroin needs sterile water to be turned into essentially an intravenous drug. However, addicts will use whatever water they can get. If it's dirty, if it's toilet water, puddle water, you know, a bottle of water that they drank out of, whatever it be, they'll use what they can get. You saw that man lick the wound right after. You saw the other guy holding the needle in his mouth. There are a lot of different issues that could come of this besides overdose. They could have severe health effects, things with their heart, infections. They could get communicable diseases by sharing needles, things like hepatitis C, HIV, all the bad stuff. Right, now the next video I want to show you is a little bit longer. It's about a 5-minute interview. I do want you to watch it. I think it's very reflective of what's going on. It can be hard to watch a little bit towards the end.
Good evening, good evening. How you doing, sir?
I'm doing alright.
Can you speak up for me?
Yeah, I'm doing alright.
What's your name, bro?
Julian.
Julian?
Yeah, Julian.
Okay, good, good. How old are you, Julian?
19.
Wow. 19?
19 years old.
Where you from, Julian?
Upper Darby.
Upper Darby, that's a nice place, ain't it?
It's alright.
What brings you down here to Kensington today?
I've been out here for like 6 or 7 months now from doing drugs. And I'm doing drugs in general probably for at least like 3, 4, 5 years. I started off doing light drugs, smoking weed. And I started doing harder drugs and stuff.
You were introduced to drugs as a child? As a teenager?
Yeah, pretty much. Probably like 14, 15 years old. I'm trying to get things together, and but it's a little hard to right now because I'm on a certain drug that you need in order to like function, and if you don't have it, you go through withdrawals and like badly, and it's a little hard to get things together when I don't have it. So I'm trying to get it so I can get my things together right now.
Now, Julian, what's your drug of choice?
I really don't like. I'm gonna just say dope. I don't really want to say the name of the dope, but it is dope.
You said dope?
Yeah, dope. And that's the drug that that's making me go through withdrawals, and which I need in order to function, in order to do things. Like if I don't have it, I can't like it's hard for me to like move around, walk. Like I go through anxiety, I can't think straight. And yeah, like I thought, like I can't eat, I can't sleep. Like it's really hard for me to do things if I don't have it in my system. But you was talking about my hands.
I was asking about them.
Yeah, these are abscesses from dope. You mind if I show you you mind if I show you a really bad one in my leg? It's a hole in my leg.
If you don't mind, I might be able to learn something from it.
All right. This is basically dead flesh. Like it starts to stink like dead flesh. Like every single time like I'm around someone, they start to smell it. They don't.
Ooh, I don't know if I can be this close. Ooh, Julian, you're only 19, man. No, I'm good. Oh,
yeah.
Julie.
Yeah. It's bad.
You need to get to the hospital, man.
It's basically getting to my bones.
You need to go to the hospital. You need to go to the hospital.
It hurts when I touch it, so I try my best to cover it. And like I said, in the hospital, rehab, first I need to go through those things first. So like when I do get out, I have something ready.
You need help, man.
But yeah, I know.
So that was Julian. At the time of this video, he said he was 19 years old. I'm 29, and it kind of like blows my mind, right? That could have happened to somebody so young. Now, I do want to clarify, I don't necessarily agree with how the guy holding the camera is speaking to Julian, especially at the beginning. You know, he was a little aggressive and not necessarily approaching him with the best tact. However, I do really appreciate this interview. You know, you heard him say dope, right? He's talking about heroin. Now, some of the other physical things you're seeing we'll talk about in a moment. But essentially what I wanted you to take out of this was he knows what's going on. Julian knows what's going on. He said it. He says, I know I need to go to rehab, right? But I can't do that. Like I don't feel well enough to do anything unless I have this medication. Part of it, I am sure, is the pain in his leg. Right? It's a bad cycle where some of the drugs he was taking caused those abscesses, so he takes more to numb the pain, and it only makes it worse. But you heard him. He can't sleep. He can't eat. He can't think straight unless he has those drugs. His brain chemistry has changed to the point where he can't really do anything but think about and want those drugs. Now, the main thing that I want you to get out of this video is at the end where the cameraman is crying, right, saying he needs help. What did Julian say? Julian said, I know. So, there's a couple different things here for us. Our job is going to be recognizing when somebody is overdosing on an opiate. Our job is not to take them off opiates. Remember, the signs and symptoms for our Narcan indications are unconsciousness, pinpoint pupils, and decreased respirations. Because what is going to kill somebody who is overdosing on opiates are those decreased respirations. Now, when I was younger, before I got into EMS, when I heard the term overdose, I pictured it as like this evil drug going into somebody's body and just like killing them, right? Like they were putting something into their body that was like little knives and it was going through and it was killing them, That's not what happens. Opiates are not inherently evil. We use them to great medical effect all the time. And when somebody overdoses, what is happening is that the drug is doing its job too well. They have taken too much of that drug, and the drug is just acting like that drug should. It is depressing their central nervous system. It is slowing the signals down that are really important, that send pain, but then also send those drives for your body to breathe. When somebody dies due to an opioid overdose, it's typically because their body stops sending signals to their diaphragm, and their diaphragm is no longer able to move, and so they stop breathing. That is the inherent danger with opioid overdoses, is the fact that they will stop breathing. Not just the fact that they're on opiates, okay? So here's one of the things that I wanted to talk about, and Sam, I'm really glad that you brought this up. People have often said that a side effect of Narcan is aggression, or that people will be mad when they wake up if you give them Narcan. If that was true, I could take this dose of Narcan right here. I have no opiates in my body, and there would be a chance that I would become aggressive if it was a true side effect. That's not how Narcan works. Picture that you had like the best day of your life. You did your favorite things with your favorite people. You had your 3 favorite meals. In the evening, you maybe had a glass of wine and had a nice bubble bath, and you got into bed feeling the most relaxed you've ever felt in your life, and you drift off to a peaceful sleep, only to be, bang, woken up at 3 a.m. on the floor of your bathroom with people in uniform screaming at you, what did you take? And you also feel like absolute shit. Narcan puts people into withdrawals. That's how it acts. It blocks opiate receptors in the brain, and it stops opiate molecules from binding. People who are addicted will go into withdrawals when you give them Narcan. So one, they feel like they have the worst flu of their life, and they have suddenly become awake in a situation that they were not awake in before. I would wager, if that happened to you, you would probably be a little upset too, or at least confused and not know what was going on. It is true that when people wake up suddenly from an overdose with Narcan, they might act aggressive, but it's born out of fear and uncertainty and confusion. It's not because they hate you, and it's not because of what the drug did to them, right? Narcan does not have a side effect of aggression. I just like to clear that up. So if we assess the 3 signs and symptoms of an opioid overdose, we're going to first manage their airway by giving them oxygen and using a BVM if they're not breathing well. This might wake them up. This has happened to me. We went to an overdose. The building was small, and there was a hard time getting our stretcher to where we needed to go. So I grabbed the bag. There was just 2 of us. I grabbed my first in bag. I went into the room. I found the guy on the floor of the bathroom, rolled him onto his back, head tilt, chin lift. He was breathing at like 12 breaths per minute, but shallow, so I put an NRB on his face, high flow oxygen, and I waited there for my crew to arrive. But the guy woke up afterwards without Narcan because we gave him some oxygen that he needed to essentially come back to consciousness. We then transported him to the hospital, high as hell, but we didn't need to give him Narcan because he was breathing okay. We kept him conscious. If we assess a severely depressed respiratory drive, we will give them Narcan. 4 milligrams or 2 milligrams, depending on what you have, up to 12 milligrams 5 minutes apart. The contraindication is adequate breathing. We are not giving people Narcan to make them not high on opiates anymore. We are giving them Narcan to make sure they breathe. I have heard providers state to me that if they assess or if their patient has told them that they have done opiates today, even if they're not there for an overdose, that they will give them Narcan. Because they, the provider, are biased, and they think that that person shouldn't be on opiates. That's not your job. Your job is to save their life if the drug is going to kill them. Okay? Now, what you saw with Julian is the new crisis that we're in. The opioid epidemic was bad enough until xylazine hit the scene. Xylazine is a not approved for human use animal sedation technique medication. It is a non-opioid medication that mimics down to the T opioid symptoms and presentation. Someone will feel like they just took heroin, but it's not going to respond to Narcan. They will still overdose, but they will not be able to be revived with Narcan because it's not an opiate. It's frequently being cut into heroin to extend the life of those effects that people take, also just the amount of drugs dealers have. It also has severe bodily effects. It is not approved for human use, and if you take xylazine, you are almost guaranteed to get necrotizing fasciitis. I'm going to show you a gross picture. This is from Vermont. These patients were in Vermont. It's not dependent on where you inject the medication. It will just happen somewhere on your body. And people will die from severe sepsis and infection if they don't have these amputated or whatever. This is some of the grossest stuff I've ever seen. And it's born out of that sick cycle of, I need this drug to feel normal. This drug is causing me to have a lot of pain, but the drug also, when I'm on it, completely gets rid of my pain, and I need that drug to feel normal, but that drug gives me severe injuries that cause me a lot of pain, but that drug stops pain, so I know on that drug, I don't feel my injuries, and it also makes me feel better, but then it's just this continual cycle. Here's a couple memes to lighten the load. Yeah, Sharon, what's your question?
If it's being cut, does that mean we're seeing a huge increase in deaths and necrotizing fasciitis because it's being cut with?
Yep.
Like the severity of people reacting to opioids is increasing?
Yep. Okay. We were seeing a decline in opioid overdose deaths in the state in 2019. COVID, 2020, it has been increasing every year. It went up 30% from 2019 to 2020. Oh, wrong button again. So here's my next question to you guys. The ones in green are the people in my family who are struggling with opiate addiction or have overdosed. Statistically, if you're in Vermont, you know somebody who is a functioning or not functioning opioid addict, whether you know it or not. We are in what we call an opioid epidemic. And that means essentially people dying from overdoses is becoming a huge problem, and it's putting strain on our medical facilities. But what caused that? And I can guarantee you, it wasn't that 3 million people woke up one day and said, you know what I want to try today? Let's get addicted to heroin. That sounds fun. Heck yeah. Girl summer, heroin summer. No, that's not what happened. Pharmaceutical companies, Purdue, created a very potent opiate called OxyContin. They lied to Congress and to other lawmakers about what it did. They claimed it was not tolerance producing, that it was safe, that it would not lead to any negative side effects, and they bribed doctors. They couldn't give them money directly, so they said, hey doc, if you prescribe your quota of OxyContin to people with pain this month, we will buy your practice brand new computers. Don't even have to say a word. You prescribe 500 people our drug, we'll get you all new stuff. And we'll cater a lunch for your crew every month that you meet your quota. The most common reason why somebody becomes addicted to opiates is because they are prescribed an opiate medication. Like I had you imagine earlier, it's tolerance producing. You take 1 pill a day to start. That will likely subside your symptoms. By the end of that first week of taking 1 pill, you'll need to take 2 to get the same effect. By the end of that week, you'll need to take 3. By the next week, you'll need to take 6. You build a tolerance to it, and if you don't have that medication, you feel the worst you've ever felt. You're not going to die from those withdrawals, but you're going to want to. That's what people report, is that they know they're not going to die, but they want to because of how bad they feel. Combine that with the knowledge that 1 pill or one $10 bag of heroin down the street is going to make you feel better. I guarantee you that if all of you had a terrible flu for weeks that wasn't going away and a doctor said, here's a pill that's going to fix you, you would take it. Their brain chemistry has changed. They don't think like you and I. But every single one of us here, no matter what you think, is one misused opioid prescription from a doctor away from being a statistic. When I was 15, I had my tonsils and adenoids removed. I was prescribed Dilaudid, which is a very strong opioid, and I remember the doctor saying, keep this next to your bed, take it whenever you're in pain. I was very lucky that my parents, whose brothers and sisters and their nieces and nephews had succumbed to this, took that pill bottle away from me and replaced it with extra strength Tylenol. I didn't even know the difference. I was very lucky. Were any of you here prescribed opiates for a surgery or for anything like that? Yeah, I'm sure you were. Okay. This is a big conversation in EMS, in society. But if you don't help these people, or if you don't want to, if you don't think that you're going to be able to give an addict Narcan over and over again, if you don't think you're going to be able to deal with that population, I'm sorry, but I don't want you in Vermont EMS. I don't. If you're going to be like any of the providers that I butted heads with constantly about treating these people like people, I don't want you here. I'm sorry. This is your job. If you want to be an EMT, your job is to keep people alive. It is not to judge them. It is not to tell them what to do with their life. It is to stop them from dying so that they might have a chance to do it themselves tomorrow. Give them another day to make that decision, because guess what? If you talk to them like Julian was talked to and you say, you need help, they are going to say, I know. Like I was talking about, there are other considerations that we can do to make this patient's life better. Telling them that they're doing something wrong is not going to help, but what you can do is advocate for them to do it safer. I'm never going to tell somebody, yes, do heroin. I will say, listen, I think you should get help. I know that you're going to continue using. That's fine. What I want is for you to be safe, and so I don't have to see you all the time. I don't want to have to be picking you up in the back of the ambulance. I want you to survive long enough so you can get off this stuff. White and brown heroin need to be dissolved in sterile water. Opioid overuse patients will use whatever water they can get. Black tar heroin needs to be dissolved in pure citric acid. Patients have been known to take lemons and limes and inject that into themselves, using it to break down that heroin. There's a culture within addicts that they think licking the needles sometimes makes the high better. So they've been doing that. They share needles, they reuse needles. All of these things can cause other life-threatening illnesses that are just bad for society. It's not our job to judge these people. It's not our job to make them feel bad about what they're doing. It is our job to ensure that they're aware of the dangers of use, but more so also dangerous use. And the best way we can help these people is by approaching them with care, empathy, and honesty, saving their life with Narcan to give them another day to make that decision to come clean. That's what we can do. Now, here's the thing. It's really hard to do this, okay? On rescue, on St. Mike's, we responded to Winooski as our primary. There were a couple weeks that I remember where I went on an overdose every shift, multiple times a shift, sometimes to the same people. There was a weekend 2 years ago in Burlington where they had 140 calls in a 48-hour period. That's unheard of. More so that 90 of those 140 calls were opioid overdoses. These patients are really hard to manage. Samantha, you're not wrong. They do tend to get mad when you wake them up with Narcan, but it's not because they hate us. They just don't know how else to express it. They typically will wake up. They'll either be happy that you saved their life but resistant to go to the hospital, or they're going to cuss at you and scream and say you ruined their high and whatever. I don't take it personally. You shouldn't either. These patients are really hard to manage if you're seeing it all the time, if you are dealing with it all the time. And I remember a moment in my career where I was with a particularly difficult overdose patient who he was about to die. We saved his life. We brought him back. And it was after a long period of doing this, and I just remember feeling hatred. And I really didn't like that. I wanted to help people, and this person made me question that, and it sucks. It really does suck. This job is hard. And I told you first week of class, I'm always going to be honest with you about the hard things. This, for me, is really personal because of my family's connection to it, because I know I'm at severe risk of potentially being addicted to opiates if I ever am prescribed or whatever. It's just in my DNA. It's not going to be easy to treat these patients. I want you to understand that. But it is important that you try. Don't take it personally. Save their life. Give them another day. That's your job. Your job is not to stop them from being addicted. We do have some backup plans. We can leave Narcan behind on scene. If we wake somebody up, they don't want to go with us, we essentially have built-in kits in our ambulance with things like this where we can leave it behind with a family member or with themselves, because Narcan wears off after 15 minutes, and opiates can last longer than that. Hey, I know you don't want to come with us to the hospital, but I want you to stay alive, so please call us back if you start to go unconscious again. If they start to go unconscious again, if they do, give them this Narcan and we'll come back, right? However many times it takes this today, we'll come back. We're here for you. But we just want you to survive. some media I recommend if you're interested in this topic. It's a little bit more like, I don't know, I don't want to say Gen Z, but a little bit more like youth-oriented. Channel 5 on YouTube, they have a really great documentary on harm reduction in Philadelphia. It covers both sides of the topic. I think they do a really good job of being unbiased about it, but if you watch it, it will make sense. There's also a 45-minute documentary called Heroin on Netflix. I highly recommend you watch it. It follows 3 women in West Virginia in like 2015 at the height of the opioid crisis in a very small town. Not a very small town, in like one of the higher populated opiate addict areas. And it follows a drug court judge, it follows a gospel worker, and a deputy fire chief who is starting to bring Narcan to the firefighters, back when Narcan wasn't readily available. Sorry, I moved on too fast. I was going to say one more thing. There are also sites in our state where people can exchange needles and pick up Narcan for themselves. Essentially, no questions asked. If you go and you say, hey, I need some needles, I need tourniquets, I need alcohol swabs, I need Narcan, they will give it to you. And there are withdrawal assistance programs, and we're even talking about like safe use spaces. Whatever you think about that personally, I don't really care. But whatever we're doing right now, it's not working. We have a Band-Aid. We don't have a fix for this. It's steadily getting worse. If you ever need to talk about something like this, talk to me. If you get out of this class and you go on calls and you're having a hard time dealing with opioid addict patients, give me a call. I will always talk to somebody about this. This is very close to my heart. I did this a lot. I know what it's like. I know it's tough. Treat these people like people and you'll feel better. Okay. Okay. Enough with the heaviness. It's time to relax with a hit of information about cannabis. Actually, I did forget one really big thing. Anyone wondering what this is? Every 7 minutes, 2 people die of an opioid overdose in our country. 44 people have died since I started this presentation. Okay, let's talk about weed. So, here you are in Vermont. It is legal for recreational use for adults over the age of 21. All right. Every year, more states are added. This is as of 2013. I believe there have been a couple more states that have added just recreational legality to cannabis. There's also a lot of medical use as well. Cannabis itself has actually grown quite a bit in how people use it. During Prohibition, throughout most of the time, you're basically just going to see just like grown flower cannabis. That's kind of what is most popularly known. There's this whole discussion about like sativa indica hybrid. Not really, doesn't matter for us. But what does kind of matter for us is how it's progressing into concentrates and synthetics. Concentrates, if you don't know, are essentially the flower processed down to essentially like the most pure form of the THC that gets people stoned. And so concentrates can have really high percentages, get people higher quicker. That can be things like you see, these are very common nowadays, just like vape pens with cannabis concentrate in them, joints, whatever. People can ingest it in a lot of different ways. Now, cannabis itself is different than a synthetic cannabis. We're going to talk about that. Things like spice and K2 and drobenol are really dangerous. They are essentially lab-created drugs to mimic the effects of opiates. I mean, not opiates, cannabis, sorry. And they can have some severe medical issues. Now, signs and symptoms of cannabis use can range, but most commonly, right, confusion, disorientation, reduced inhibition, short attention span, like not really remembering a lot that's going on. They can be euphoric. They can have some nausea, lethargy. You're going to see like the glassy red stoner eyes. They can also have pretty severe like panic attacks. It's one of those drugs that can like amplify somebody's anxiety. And then, of course, increased hunger. That's just one of those things. Now, there are a couple different things in cannabis just to be aware of. Just because you smell it or you see somebody smoking something that smells like cannabis, it doesn't necessarily mean it has any psychoactive drug in it. THC is the psychoactive component of cannabis, whereas CBD is another major chemical component that doesn't actually get people high. When people talk about medicinal marijuana, people don't tend to understand this, is that most of the time we are talking about CBD, not THC. There's very little medical benefit to getting somebody high, whereas CBD is showing really great merit for things like seizures, Parkinson's, anxiety, pain, and PTSD. So people aren't necessarily just smoking a bunch of weed to feel better. They oftentimes are doing CBD treatments to help with something like this. There are products that both have THC and CBD, and for the most part, if we're talking about abuse of it or just like recreational use, people are not recreationally abusing CBD. They are doing THC to elicit that stoned effect. There's quite a few ways people can ingest this. It can be oral. People can make drinks. They can make edibles. When I moved to Colorado, my mind was shattered with what I saw, where I just wasn't expecting it. But you walk into a dispensary and there are drinks. There are like fruity drinks with hundreds of milligrams of THC in it. There are gummies. There are topical lotions. There are tinctures. Basically, any way that you can think something be made, cannabis can be in there. Now, one of the main things we see if somebody takes an edible, eats cannabis, is that it's typically a really slow onset, but they get extra high. The way it's metabolized is different than smoking it, so it has a stronger effect. Most often, if we see people on the ambulance due to like a cannabis thing, it's because they ate too much and they're not prepared for how strong of a high that produces. Can really make people panic and think they're going to die when really they probably will not. Most common form of taking THC is inhalation, whether it's lighting the flower on fire or vaporizing the concentrates or whatever. This is a quick onset, also most common. And then also there are topical lotions like salves, tinctures that people dip into their mouth, eye drops. Really, just like because now it's legal, there have been a lot of different explosions in ways people can take cannabis. If you have a Hulu subscription, I think, if you're just interested to see what people do, this show Bong Appetit is really interesting. They essentially combine professional chefs, weed enthusiasts, and weed scientists to create meals that have cannabis in every single aspect of it. It's really wonky and weird, but if you're interested, take a watch. I thought it was kind of funny. But you can also see just like candies and brightly packaged wrappers, and they make like nerd rope with weed in it, and gummy bears and all that kind of stuff. So don't be surprised if you're surprised by how somebody takes cannabis. So this is the other question we often have to talk about. THC cannabis is not typically dangerous. It is hard to overdose or have a toxicity of a drug to kill you. There's this idea of the LD50, which is essentially life and death, 50% chance. This is a term that we use for toxicity of drugs. So how much of that drug would someone need to take per their body weight to have a 50% chance of dying due to toxicity of that drug? You can see on this chart here, prescription opiates are way up here. This is poisoning deaths for various drugs, and cannabis is way at the bottom. It is really challenging to ingest enough cannabis at one time to have a toxic effect, okay? For example, cannabis has an LD50 of 1,270 milligrams per kilogram. So someone would have to take 1,270 milligrams per kilogram that they weigh to have a 50% chance of dying. If you want to do the math and see how much I weigh, go ahead, but I would need to consume 132,080 milligrams of THC in one dose at one time to have a 50% chance of dying. So it takes a lot, all right? However, kids are smaller, and as legality is starting to bloom, people are packing more and more milligrams of THC into very yummy looking candies and gummies. There are cases where children have eaten a whole like thing of gummies with like 20,000 milligrams total in there and had toxicity. So it's not something we can just disregard. But if you're talking to an adult and they're claiming they're going to overdose on cannabis, it's statistically impossible. A vast majority of deaths involving THC are due to mixing of a lot of drugs. When they get those tox screens back, they'll see like cannabis, heroin, cocaine, LSD, just like a lot of different things. Weed is one of those drugs that people do alongside other ones. If they're already high on something, it's very easy to smoke something, right, and just add on to it. But it's really hard for them to traditionally overdose or have toxicity from cannabis. All right. I've gone to quite a few calls where people are really high. They just took their first edible. Went to campus one time, and there was this girl with her friends who they were like, you should have ate half the brownie, and she wanted to eat the whole thing. And we responded, and she's sitting there, and she looks at me, and she goes, if I close my eyes, I'm going to die. And I said, hey, I understand that you're feeling really anxious right now. Is all you had that brownie? She said, I didn't have had anything to drink. I just had that brownie, but I know I'm going to die if I close my eyes. And I said, I highly doubt that. Really, what I think is best for you, why don't we stay here? Why don't your friends get you some water and a nice comfy blanket? Put on a Disney movie or something. She said, no, I need to go to the hospital right now. I'm going to die. And I was like, okay. She was fine. She was just really high. People with these high doses in edibles tend to get paranoid. They can get really anxious, have panic attacks. That can lead to situations like this. If somebody is only taking cannabis, they're not going to die. Here is the LD50 for nicotine. Nicotine is actually one of the more deadly drugs. If we used to do like studies, St. Mike's does studies on nicotine, and they had to like have a big vial of pure nicotine, and that is the most protected locked up drug they had on campus, because if you just like dip your finger without a glove into pure nicotine, you could very severely die. Fentanyl is one of the next ones. Heroin and LSD. A little bit more milligram per kilogram. And then we've got cannabis and CBD up here. Takes a lot. Almost impossible. Not impossible, almost impossible. Psychological first aid is really the best thing we can do for these people. People can get paranoid by what's going on. They might be thinking something bad is happening. We should always transport a voluntary transport to the hospital. We're never just going to say, no, you're lame, you can't handle your weed. If they want to go to the hospital, we're going to bring them to the hospital. Now, the other thing is it's really hard to assess for if somebody is on cannabis or really stoned. This is one of the pushback to like legality is intoxicated driving, like DUIs, right? It does affect people's ability to drive. It does affect their ability to, operate heavy machinery. So while it's acutely safe, it is not safe when combined with other drugs or the actions of intoxicated people. One of the worst calls I was on was potentially because of a stoned driver. This was in Heinsberg more than a couple years ago, but a 18-year-old kid was driving really fast in his Civic. He's going about 80 miles an hour on the back roads of Heinsberg, and he crossed the line, struck a bicyclist, and then crashed his car. What you're seeing is what I saw when I got on scene, this car. The bicyclist was dead, and so was the kid. Very, very badly beaten up. The bicyclist was about 50 yards away from where he was struck. He was sent flying into the field. He was essentially completely broken. And the kid was really, really deformed, and it was an awful situation. I remember this very vividly because I remember looking in the car and seeing his keychain. It was like a lanyard, and it was just all like weed leaves, right? And they did tests, and they did find that it was in his system. We don't know if he was high at the time, but it seems likely. So again, I'm not saying that it's completely safe. People do dumb things, but when we're talking about overdoses, we're not likely to see a THC, a weed overdose. Now, the last thing for this weed stuff here is the synthetics. Because they're, chemically similar but not the same, they're supposed to mimic the sensation of cannabis. It's really weird how this works, but essentially it's similar to bath salts, where people have this chemical structure that mimics cannabis, and it is not cannabis, so it's technically legal. Like, there are gas stations and stuff where you can find fake weed that they're selling legally because it's not weed. And then once the legislature catches up, identifies that molecule that they're using, they will just add a random other molecule onto that chemical binding so it's not the same anymore, and then just repackage and resell. And that just is very unsafe. So where people get their cannabis is really important. That's one of the benefits of legalization, is that people tend to get it from reputable sources. However, if they're buying from a random person who gives them spice, or they just buy spice, whatever, this can lead to like seizures, some chest pain situations, and like severe other mental status stuff. So it's just really important that if you're talking to somebody who is having these symptoms and they're talking about cannabis or whatever, ask them where they got it, do a little bit of assessment. There's not much we can do besides routine patient care. There's no medications to give. Keep them breathing, get the history, take their vitals, bring them to the hospital, get the best possible history for the doctors. But yes, there is a chance that it could be fake weed and it could be bad. Last memes. You guys have any questions?